Welcome to the special edition of Healthcare Radio's podcast on the occasion of World Cancer Day. Today we have Dr. KG Kallur with us. He's the director of molecular imaging and nuclear medicine at SCG Cancer Center, Bangalore. He has over 35 years of experience. Dr. Kallur's expertise lies in general nuclear medicine, PET-CT imaging, and his special areas of interest include theranostics and radiopharmacy. He has played a significant role in establishing India's first FDA-compliant cyclotron and PET radiopharmaceutical unit. Welcome, Dr. Kallur.
Thank you. Thank you for inviting me.
My first question is, nuclear medicine has come a long way from the rectilinear scanner in the 1940s to the modern day advanced digital PET-CT or PET-MRI scanners. What
Yes.
have been the most significant changes that you have seen in the field of nuclear medicine over the years in the areas of oncology, neurology, and cardiology?
So let me begin historically. As you told, it was a rectilinear scanner. When I was studying my nuclear medicine post-graduation at TMH, Mumbai, those days we had a rectilinear scanner. The new generation of students may not have seen it at all. Okay. So that was how the science has progressed, because we were seeing the images only as few dots here and there. Okay. So it was imagination at its best. Okay. From that time onwards, now we have moved to almost digital scanners, digital gamma cameras, and digital PET-CTs, where the images are extremely crisp, clear, and there is no imagination at all. So you will see the things, and we know the disease very much well very early in its infancy, or I can say, and also how much is the extent of the disease in the body we can see in one sweep of the body. So initially, say about 30-40 years ago, we started having what is called as Hanger gamma cameras. That was the time when we just started seeing the functional image. The nuclear medicine, the difference between nuclear medicine and the regular conventional imaging such as CT, MR, or ultrasound is that the CT, ultrasound, or MRI, they are form imaging. Form stands for anatomical imaging. You'll see the images are described. Okay, some lesion is seen, the organ is seen, this is how one seen, and it is explained, this is how it is. But the nuclear medicine is different. We see the organ, how it is functioning. We use certain ligands which are tagged with isotope. The commonest ones used are technetium isotope, iodine 131, and recently in the PET F18 labeled and gallium labeled isotopes. So we label them with certain ligands, these are chemicals which are exploited for some of the function of the particular organ of interest. And those functions will always alter first, even before the anatomical changes happen. The physiological changes always precede the anatomical changes. The chemistry or abnormal physiology will always happen much before we start seeing the changes in the CT, ultrasound, or MRI. So we can pick up the problems with the patients very much early. So that is the difference. Now, what has happened earlier, we were seeing only the functional imaging. The surgeon or the treating doctor also wants the anatomical imaging. So we were having a problem at least about 15 years ago. Then came the amalgamation of both the functional as well as anatomical imaging in the form of SPECT-CT. That is a gamma camera image fused with the CT. So both the equipments are in the same gantry. So when the patient goes through the gantry, you will get the functional information. On top of that, anatomical information is also superimposed. So you have exquisite anatomical details. Along with that, the functional information. So we have a greater degree of confidence in reporting what is the problem with the patient. Suppose there is a structural change. In that structural changes, what is the problem of what is the functional changes that have happened? So we can pick up these lesions very much earlier. So that is the advent of SPECT-CT. So these all things have come in the last 10 years. So, and with every passing year, the changes will happen. Technological changes are happening both in the CT image or MRI imaging as well as the functional information. So definitely the information coming out now compared to what it was earlier, is far superior than the what we were seeing about a decade ago.
So the PET has been a valuable research tool for many decades, as you said, and its real growth into the clinical application has occurred in the last decade or so.
Yes.
Recent advances in imaging techniques and have further widened the comprehensive and the convergent application of PET in the clinical management of cancer. Could you brief us on PET-CT based imaging techniques relevant in India and their clinical benefits?
So the first PET to come was in Tata Memorial or Radiation Medicine Center about 15 years ago. That time there was only a PET. Again, as I told you, it was only a functional information. So now we have both a CT also fused in that. So we are having a PET CT. So what happens with the PET CT? Earlier we were having some difficulty in describing certain lesions we were seeing in the PET, because the surgeon wants to see what is happening. Suppose we are describing a lesion, he has to see it to believe it, because if he wants to operate, he has to identify where is the problem, where is the organ, where is the lesion within the description given by the PET. So the moment we added the CT, so we started seeing better quality images, and the information is coming, very superior information is coming to all the treating doctors, and they are appreciating it in their day-to-day practice. And for the last 1 decade, earlier there were only few. I was one of the few private nuclear medicine guy to start the PET CT. Ours was only the third PET CT in the country. Today we have a PET CT in almost all taluka places, tier 3 cities also now. In Bangalore alone, earlier mine was the only one. Now there are 12 PET CT centers. So like that, they have seen that how it makes a difference in the diagnosis of the patient, those who come with the cancer, and also during the treatment, how the treatment is working, whether treatment is working or not, and what we can do for the patients after the treatment. Can we just keep wait and watch, or further treatment is required? So all these informations are possible now with the advent of PET CT. And now almost all, I can say, major cities are having a PET CT. And the isotopes used, commonest isotopes used is what is called as radioactive glucose by almost all centers in the country, for which you need what is called as a medical cyclotron or a baby cyclotron, where we produce radioactive glucose called FDG. So now there are about 15 to 20 cyclotrons spread across the country, and each cyclotron can cater to around 15 to 20 PET CT centers. So typically they produce in the early morning, and the dose reaches all the peripheral centers by 8 o'clock or 9 o'clock. So we can carry out the work for next 4 to 5 hours. So this is the practice of PET CT, nuclear medicine in the major cities of the country.
PET or CT's undoubted advantages are valuable in clinical oncology and all fields of diagnosis, staging, and treatment. What's the role of PET or CT in the management of various tumors, and what are the medico-economic usefulness?
Yes. What happens in any, I'll just give you an example how a workup of a cancer patient begins, a diagnostic workup. Suppose a lady comes with, say, a breast lump. Clinician knows just by an investigation or just by clinical examination palpation, he knows that there is a lump. Now, the high index of suspicion, elderly lady, okay, so that whether that lump, what we are palpating, is it a cancer or is it benign thing? So host of investigations are done. So what they usually do, typically a mammogram of that breast. Then after that mammogram, ultrasound. Now they say there is a high probability of malignancy there. Then MRI may be required. Then they suggest you do a biopsy. Then surgeon wants to know whether it is still localized or whether it has spread. To identify that, there are 3-4 organs which commonly it spreads. That is lung, bones, liver, or any other peripheral soft tissue organ. So for which They might advise whether it has spread to the lungs, you do a CT scan of the lung. Whether it has spread to the abdomen, say liver, you do ultrasound or CT scan of the liver. Whether it has spread to the bone, you do a bone scan. Suppose the patient has some neurological deficits, some headache or some neurological deficits, there is a suspicion that it might have gone to the brain. So you do brain MRI. So a patient walks in with just a breast lump, has to undergo this many investigations just to conclude that, okay, the disease is localized or it has spread. Now you can imagine the agony the patient has to go through for almost all these scans will take almost a week to do. So patient, if everything is there in one center, they can undergo everything under the roof in one place. But suppose in another small city, a CT scan may be in another place, an MRI may be in another place, ultrasound specialist is in some other place. So patient has to go from pillar to post just to come to a conclusion. That all has been negated now. In one investigation from head to foot, all these investigations can be avoided. So multiple investigation can be avoided. So in one go, you know whether the tumor is located only at one place, whether it has spread to other organs or regional lymph nodes, etc., etc. So this will give you in 1 hour time, you have all the information, a breast lump, whether it has spread to the axillary nodes, whether it has spread to the lung, liver, bone, or maybe brain. So in 20 minutes, you have the answer. So based on this, we are going to cut down many unnecessary procedures. But when I started my PET-CT career about 10-15 years ago, that it was very difficult to convince at that time. Anything new will be always questioned. So hey, it is very expensive. My patients cannot afford. So they keep adding these investigations. So if you take into account all the investigations done, the patients usually spend much more money than a single PET-CT investigation. That took some time for us to convince all the referring consultants or the medical fraternity to understand the value for money. Okay, it may be one time the patient may end up paying slightly more money than giving multiple payments for multiple investigations. So, and yet you have better answers than all other investigations put together. So this is how we are cutting down many unnecessary procedures and very fast the diagnosis. The patients also want to very quickly the information what is happening. So you will have very quick answers, quick decisions can be taken what is best needed for the patients based on the whole body PET-CT now. That is the advantage with the PET-CT.
In nuclear medicine, the Theranostics approach is an established tool for specific molecular targeting, both for diagnostic and therapy. Thanks to the ongoing R&D of newer radiopharmaceuticals and diagnostic techniques, theranostic use of nuclear medicine have been continually increasing. Could you brief us on the therapy or treatment aspects of nuclear medicine?
Okay. So nuclear medicine is a wonderful tool for a diagnosis as well as therapy.
Okay.
Diagnosis comes as an evidence, and based on evidence, you are doing a therapy. Theranostics is a new buzzword. You have a diagnostic evidence. You see, my molecule is going to, this isotope is going and sitting in this problematic area. Can we use, that is for diagnosis, diagnostics. Now, when we use it for diagnostic purpose, the isotope used is very minuscule quantity. It will not have any desired therapeutic implications. And in case the same thing, we can use it in larger quantity, it becomes therapy. So diagnosis plus therapy, diagnostics plus therapy. The new terminology is coming called as theranostics. So you are not blindly taking a shot. You know that you have identified, you know that that particular mass or a cancer tissue is concentrating that particular isotope, and use the same isotope in a larger quantity so that it is going to treat. Why we want to do this? Because there is a diagnostic evidence. Today we all talk about what is called as evidence-based practice. You need an evidence to treat this patient using the same molecule. By way of diagnosis, you have evidence and treat it with a larger quantity of the isotopes. That is why the word is called a Theranostics. We have been actually practicing this for last 50 years. Only now it is gaining a lot of prominence. In 50 years, we were commonly using an isotope called iodine 131 for treatment of some thyroid problems. Most commonly treated problem was what is called as Graves' disease or a thyrotoxicosis. So here we were using earlier a small dose of iodine 131. In a thyrotoxicosis, we know that it consumes a lot of this iodine for its production, overproduction of the hormones. So my diagnostic iodine was going and sitting in the thyroid gland. Based on the uptake patterns in the thyroid gland, we used to diagnose, okay, this patient is having Graves pattern or hyperthyroidism. It is using iodine. And because we had an evidence, we were giving more dose next day, iodine 131, and it was going and sitting in the thyroid gland only and not sitting anywhere else in the body. So you're not giving unnecessary radiation to any other organ. Only thyroid is taking up maximally. And because it is radioactive, the thyroid gland was painlessly, okay, very comfortably, it was destroyed because it was like doing a surgery for the patient. So we were destroying the thyroid gland because it is functioning more. So the production of the hormones comes down. So this is the very earliest evidence of what is called as the Theranostics. Okay. The same thing we are using even now. Almost all centers across the country, we use it for cancer of the thyroid gland. Same thing. So we will give iodine 131 after the thyroid has been removed. And we want to know if it is remaining some amount of thyroid tissue left behind in the neck, or if it has spread elsewhere in the body. We use a larger quantity of iodine 131, and it will go and give a lot of radiation only to the cancer cell. The beauty of this is these isotopes will not go anywhere else. It will go only to the problematic area. Why we see typically the side effects in any cancer therapy? Because any chemotherapy drug or anything, it will usually not distinguish between a cancer cell and a normal cell. The normal cells get affected by the chemotherapy drug, that will manifest as a side effect. Whereas the cancer cells will accumulate those drugs and they will also be destroyed by the chemotherapy drugs. But the innocent bystander, the normal tissues, they also accumulate that chemotherapy drug, and that is why they get a lot of side effects, such as the commonest ones are vomiting, diarrhea, skin changes, okay, and some bleeding tendencies. Bone marrow also gets affected. The bone production, the blood production comes down. It's all because of the side effects of the chemotherapy. What happens in the nuclear medicine? Because we are exploiting certain physiological function of that particular cancer, my isotope goes only there, and other tissues are not at all utilizing that particular function, or it is not there. So when I give radioactive iodine, which is programmed to home in on the problematic areas or problematic physiological function or particular chemistry, which happens only in cancer cell, the isotope goes only to the cancer cell and not to the surrounding normal tissue. That is why you usually never see any significant side effects at all with the nuclear medicine therapies. Iodine thyrotoxicosis is the commonest prescribed theranostics in the country or anywhere else in the world. The next comes carcinoma thyroid, which we all treat. And because it is very significant accumulation happens in the problematic area or only the cancer cells, the results are always phenomenal. That is why even though patient comes with a lot of disease spread anywhere else in the body, these patients survive for years together because we are giving maximum radiation kill to the cancer cells and not the surrounding normal cells. So because of that, their survival is better. The quality of life is better because you are not affecting the isotope is not going and touching the normal tissue. So we need a good quality of life also for the patient, unfortunate fellow who has got a cancer. So we are targeting the cancer cells, kill the cancer cells, and also give better quality of life. Now, a lot of research is happening in the theranostics field. Now, newer isotopes are coming with what is called as gallium-68, And we are trying to identify certain ligands which go to only to the cancer cells. So for example, the new isotopes which have come, they are gallium-68 labeled what is called as DOTANOC. It goes only to neuroendocrine tumors, which are very rare tumors. But today we are having such a fantastic tumor control, fantastic diagnostic quality. The patients are living comfortably. We may not be able to eradicate the disease, but we are giving them almost near normal lifestyle. Their quality of life is phenomenal. Another classic example which we can give is cancer of the prostate. So ultimately, now for elderly person, a male patient is if is more than 65, 70, he is 1 out of 10 person he is likely to get a prostate cancer. It is becoming quite common because of the elderly population now. Elderly population is increasing, so we can expect more number of prostate cancers. So they also live longer, but at the end, they also have disease throughout the body. Now we have a specific ligand which targets only the prostate cancer cell called as prostate surface membrane antigen, which is expressed only in the prostate cancer cells and nowhere else. So what happens when I give this therapy, it goes only to those cancer cells. These cancer cells are exquisitely radiosensitive. So we are giving them a good radiation without affecting the surrounding normal cells. So patients are surviving better now. They are having less number of complications because of the advanced disease, and the overall quality of life has also improved dramatically now in our country. And I can say that these types of therapies are very quickly adopted in our country. It is a bit difficult in Europe and USA because of there are certain regulations there. Here also regulations are there, but the adoption of new technology and new theranostics is quite rapid in our country. That much I can proudly say that our patients here now are getting a excellent treatment with the theranostics. The same thing now, I had told you only few malignancies, say thyroid cancer, prostate cancer, or neuroendocrine tumor cancer. Now a new agent is coming called as what is called as FAPI. These are the cancer cells, special type of cancer cells. They act like a supporting structure for a cancer cell. It forms a base for the cancer mass to grow. For example, just to give an example, suppose you see a 10 cc volume cancer mass. In that, 90 cc is the supporting structure done by what are called a fibroblast activity, cancer-associated fibroblast. These are the cells. They form like a supporting structure for only 10% of the cancer mass, cancer cells. In 10 cc mass, 90 cc is actually, 9 cc is actually the supporting structure, and only 1 cc is a cancer mass. So you can see that there is a large area of a supporting structure. Today, we have a wonderful diagnostic agent called as FAPI. Now, we are labeling it, and we are injecting, and we are seeing the tumor so exquisitely in great detail and much more better than the standard PET CT, what everyone does, what is using an isotope called as fluorodeoxyglucose. So whatever is not seen even in fluorodeoxyglucose, I have told you about if FDG PET scan is good, gold standard. Now we have moved ahead, much more specific, more sensitive to pick up the tumors than fluorodeoxyglucose PET scan. Why we are doing? Because now I have identified this a cancer-associated fibroblast, which form the bulk of the tumor, and I am able to diagnose the tumor much more superior than any imaging modality. Now I just change the isotope and put a therapeutic isotope there. So now virtually in future, we can treat almost all cancers. 90% of the malignancies, cancer cells. Okay. Common cancers which we see in our day-to-day practice can be treated now in future. It is too early to say these words, but I know that same thing we were talking about neuroendocrine tumor and prostate cancer about 10, 12 years ago, but today it is a buzzword. Everyone talks about this. The same thing is going to happen for what is called as a FAPI scan and a FAPI therapy in future. It is very, very early. We have just started doing cases in India now, especially in our center. And we are seeing some amazing results for patients who have no other alternative. I call these patients as TINA patients. TINA does not stand for a name of a patient or a female patient. TINA stands for there is no alternative. Under the sun, everything, whatever is the standard practice practiced worldwide, or there are guidelines that support this type of a cancer has to be treated by certain guidelines are there. When you have finished everything, we know this is common practice. You would have seen in some of your relatives, they survive for some 4 or 5 years and ultimately they succumb to the disease. End stage disease will come where nothing works. So this is the time when we have just started applying this new thought process and new scientific evidence, the new diagnostic evidence, and a new theranostic possibilities are coming up now. So we are seeing that these patients at the end of their life cycle, they are having a better quality of life. Some of my patients, when we have treated, they say, why this was not offered to me earlier? Because it has only come now. Okay, so we are going to see these type of therapies in future. And the beauty of this is, again, as I told you, no side effects. The patients are so tuned to the side effects. They also expect the same type of side effects with this FAPI therapy, which we are doing now. But when we finish the therapy, they ask, is it finished? I did not have anything at all. I did not feel anything. So this is the surprise on their face. It is, they are happy that they did not experience any side effects. So their pain minimizes, the tumor burden comes down, their quality of life is improving. At present, I am doing only at the last stage patient. I told you, TINA patients.
Yeah.
In future, if we can adopt that, you see, when we are giving some benefit to the end stage disease, if we would have added it a bit earlier, probably patient would have had a better survival and a better quality of life also. So this is what is going to happen, madam, in future. It is just a beginning. And we have just started doing it in India. We are doing in our center because I'm blessed with a lot of scientific people, and radiochemistry guys are required to do all these things. And I'm blessed. My department is blessed with the good people who can do. It is a team effort. It is not a single individual agent. For one therapy, at least some 5-6 people are involved in ultimately before we deliver that radiation dose to the patient. And it is a very exciting field for a nuclear medicine to be in now. And exciting things are likely to happen in another 5 to 10 years. The way we treat the patients is likely to change. You might have just got a gist of what I have told you, that we want to deliver maximum for the patient with the least complications and the least side effects. And yet there is a evidence-based practice here. At present, this is the new thing. So the questions will always be asked in fraternity. Where is the evidence? The evidence is mounting up now. So gradually, and I'm sure in years to come, we'll be doing a lot of these therapies.
Okay, so we can call this as a disruptive innovation in nuclear medicine.
Yes, destructive. Don't use that word destructive. Let us.
No, disruptive. Disruptive.
Yes, disruptive. Yes, definitely. It is going to change the way we give radiotherapy to the patients. Radiotherapy is a standard of care for most of the patients. They usually take external radiotherapy. Now, suppose the patient comes with a big mass and a disease elsewhere in the body also. What is our current radiotherapy going to do? Patients are not going to benefit by such type of radiotherapy, external radiotherapy. Now, if I give a theranostic application like this, my dose will go to the primary tumor or disease anywhere else in the body in one go. So definitely this is going to be disruptive, as you correctly brought it out, the word disruptive technology, I can say, for benefit of the patient. In one go, give maximum dose to the patient with the least side effects. What this does, this therapy is also doing is, you see, the body immunity always tries to fight against infection or the tumor also. But why the tumors escape the notice of our own body immunity? There are some certain cells called as killer cells. Some WBCs are there. They have to identify these mass, whatever is developing, as a foreign body. It has to go and attack those cancer cells and finish them off. Why it does not happen? Because these cancer cells are very wise. They produce a certain kind of a cocoon around them by way of producing these cancer-associated fibroblasts. These are called as CAFs. CAFs are the part of the body cells only. So when your killer, our own body immunity comes near these CAF cells, it identifies, oh, this is my own product, my own part. This is my own structure. I will not attack, and it will go back. Now, if we destroy these CAFs, suddenly we stimulate the body's immunity. Our body starts recognizing, the killer cells start, hey, something has escaped my attention, something is here, they start attacking the cancer cells. This is what we have seen, and this is what is going to happen in future. We are going to stimulate the body's innate immunity and its ability to attack the cancer cells. And also, these cancer-associated fibroblasts also act like a barrier for the chemotherapy drugs. So if you remove this barrier, the patients who are not responding to chemotherapies, initially patients respond to a certain level, then they become refractive. So why they become refractive? Because of these cancer-associated fibroblasts. Remove the cancer-associated fibroblasts, so the patients can be treated again with the chemotherapy drugs. They are becoming exquisitely chemosensitive again. So many new things are happening. This is all going to be disruptive for disruptive technology or disruptive theranostic capabilities, I can tell. But ultimately, for whom? For the patient's benefit.
Doctor, you have been associated with this field for more than 35 years. Tell us about your experience and how the field, technology, and the equipment have evolved over the period of time from imaging to treatment.
I have already elaborated in my talk now, but again, I'll give you an example. I'll conclude it in a nutshell. What happened about 25, 30 years ago? The technology was its infancy, okay? And we were not able to diagnose the tumor nicely, but we started seeing the tumors, at least earlier. Earlier, it was only a clinical examination and the clinical acumen of the treating doctor by palpation. But now we wanted to see inside the body what is happening. That is where a nuclear medicine utilizing the isotopes came into the picture, and we started exploiting the physiology. And then we have superimposed on that the CT and MRI. So we are seeing that inside the body, what is happening in exquisite details. So this has come as a shot in the arm of a treating doctor. So he uses his clinical acumen. He is seeing what is happening, and he is seeing the tumor which he cannot feel or palpate by his hands. Okay, so he is taking a proper decision, and proper staging is happening, and what is based on these image-based, what I can say, staging, we are able to do a proper treatment for the patients. Now, as you told, the technology is gradually improving. So take, for example, a mobile technology, mobile phone. Earlier, about 15, 20 years back, mobiles were huge. They were almost 6 inches. My first phone was almost 6 inch long. Now, very small, you can keep it in the pocket. Earlier, we were not having a camera, or all the sophisticated things are coming now. Even internet, you can browse so beautifully in the mobile. That is the technological advance happening in the mobile field. Same thing, the technological advances are happening in the imaging field also. And there is something called the digital technology. Now, earlier cameras were what are called as analog cameras. Now, the digital cameras are coming, where we can do the image in great detail, anatomical detail. For example, if some lesion is seen, 3 of us are sitting, 2 may agree that, okay, there is an abnormality. And one of my colleagues says, no, I'm not seeing an abnormality. Now with the digital technology, The images are crisp. There is no disagreement at all. So everyone will agree now. Okay, yeah. All three of us say, yes, there is an abnormality here. So this has come in the way of in the gamma camera and PET CT. There are what are called as crystals, because we identify certain light. It is too complex to explain you here. There are certain crystals in the camera. So the crystals have evolved in a better way. Earlier there was BGO crystals. Now there are LYSO crystals. Okay, so new crystal technology has developed, and most of the companies are investing in the newer crystals. So basically, to identify more light, more information coming from the patients. So more information comes, better image quality, crisp, clear image quality. And because now the scanners are also very fast. Earlier, I can tell that I used to finish my whole body scan in about 25 to 30 minutes. Then my next scanner came, we were able to do in 15 minutes. Today, we are routinely doing about 5 minutes. The new scanners are also coming now. I can do whole body scan in 1 minute. You may be wondering why 1 minute. You see, we deal with the cancer patients. There are patients who cannot lie down at all for 5 to 10 minutes. They have they have a lot of pain, excruciating pain. We have to many times call the anesthetist also to finish off our job, or give a lot of painkillers so that they cooperate and finish the scan. It is really disheartening for us to see such patients with all those problems. Many times we feel so sad to do all these works for them, because we see day in and day out their pain and suffering. Now, is there a technology where I can finish off their whole body scan very quickly? That is the digital technology which is coming now. There are new scanners coming where we can finish. At present, we are doing in our center also. I can finish whole body scan in 1 minute. It makes a difference for certain patients. It may not be for all patients, but a cancer patient who cannot lie down. There are few patients who have claustrophobia. They don't want to lie down in a machine because they go into the tunnel. They are afraid of that going into the tunnel. They never ever cooperate. Say, for example, such patient, I will ask him to just close his eyes for 1 minute. I think he can cooperate. In 1 minute, I will finish his whole scan and you have the answer. This is how the technology has evolved. And because we are seeing the tumor also nicely, because we are bringing out a lot of new innovative chemistries, ligands, radiochemistry, we are diagnosing the cancers very nicely and also using the same thing for theranostics. This is how the technology has evolved in the last 2 decades.
So, how do you see the training of residents and technologists in our nuclear medicine training programs, which is most important?
Yes. What happened when I was doing my nuclear medicine degree, there was only one center. That was at Tata Memorial Hospital.
Okay.
So that was a diploma offered at that time. There was no MD at that time. Today, many private hospitals and big teaching hospitals have started a nuclear medicine department. Now, these post-graduations are also available. MDs are available, diploma is available, and there is something called a diploma, DNB also is available. Many private hospitals are offering this. So we were having a difficulty in recruiting, identifying the technologists as well as the nuclear medicine doctor. Very few. Even today, we are very few compared to any other specialty. But because now many post-graduation teaching hospitals have started this course, we are seeing a lot of young graduates coming now into the nuclear medicine. That is very heartening to see. Otherwise, it was stagnant. We need young blood also. They are at a right time at the right place. We have seen how the technology has evolved from almost nothing to what is the best offered now. The new graduates who are coming out, almost all of them are seeing the best technology available to them now. So they are coming out trained very nicely under all these teaching institutions and large private hospitals also. There is a huge demand coming up now. I am seeing requests from many of the private centers here and there across the country If you have some nuclear medicine technologist or a doctor, please let us know if are they willing to join. That means this specialty is growing now. There is a lot of demand, and fortunately, compared to what it was about 10 years ago, a lot of new graduates are taking up nuclear medicine. It is a very exciting field to be in right now.
Doctor, the last question. How can we increase the availability of nuclear medicine facilities in rural areas of India?
This is a problem. Nuclear medicine practice is usually institution-based practice. Of course, nowadays, small private centers, some entrepreneurs have started investing it and coming out. But what happens in you need a isotope supply, a stable isotope supply. That is why the stable these isotopes cannot be produced, and some of them are not available in our country. We have to import. So you need some nearby airport, a large airport. From there, at least another 100 to 200 kilometers, we have to transfer by a private vehicle. So because of this problem, the nuclear medicine was not thriving at all. Now, so many new airports are coming up. So the isotope is able to reach the center very early. Why we need airport facility is because these isotopes are short-lived. They cannot be kept for months together. They have typically a lifespan of 5 to 7 days. So you have to supply this very quickly. That is for a conventional nuclear medicine. And in the PET-CT, the isotopes life, which is commonly used across 99% of the centers in the world, is what is called as fluorodeoxyglucose, FDG PET scan. Here, for example, I sit in a Bangalore. I want to send it to Belgaum. I can send by flight or by the road, or even to Bangalore, about 400 kilometers by road. If they want 10 doses, I have to load 100 doses here in the beginning. So 90 doses goes waste only during the transit, so that at least 10 doses reach him. But we cannot build the peripheral center 100 doses, because otherwise he will never become viable. For us, the production cost for 1 dose or 100 doses is the same. So we want everybody to survive and flourish. More centers come means it becomes viable for everybody. And cyclotron is required for practice of a PET-CT at present in most centers in the world or even in India. But it is set to change, because as I told you, there is something called as gallium-68 generator. It will survive in any department it has a life of 270 days. It can work for almost 6 to 7 months. We can buy this and keep it in the department. Whenever patient comes, we can, now the radiochemistry or chemistry is changing a lot. Newer ligands are coming. These ligands are kept in the department because they are not radioactive. Now we identify a patient comes, oh, this patient needs this particular PET scan. You take that ligand and the isotope is there in your department. You just add and synthesize using the synthesis modules and inject the patient and finish off. So you're not dependent on now for the supply of the isotope. So the future is really bright for even the interiors where there is no availability of isotope or airport. This one generator can reach, it can take maybe 1 week from a nearest airport and it will reach the department. We know that the isotope is there all the time and it will survive for 6 to 7 months. You keep taking out the isotope, add it to a particular chemical and keep doing the PET scan. This is bound to happen. It is already happening. And even the peripheral centers will also start doing the PET scan. It is going to become popular.
Thank you, doctor. Thank you for your time and giving us valuable insights into nuclear medicine and molecular imaging. Thank you.
Thank you.